Next up, we have Dr. Amy Trahan to talk about lung cancer screening and the updates from the U.S. Preventive Task Force. Dr. Trahan?
Hi, thank you so much. So yeah, we will briefly talk about the U.S. Preventive Services Task Force update, which was just released in March of 2021. Next slide. So just general basics, which most of you are very familiar with. Lung cancer is the second most common cancer diagnosis in the US, but the leading cause of cancer death. And the numbers there, 223,000 diagnoses and 135,000 deaths from lung cancer in 2020 alone. The primary risk factor is cigarette smoking, although we are seeing an increased incidence of lung cancer in non-smokers. Still 90% of the cases are related to cigarette smoking. The overall survival rate for lung cancer is pretty dismal, 20% overall, but this is partly because of the diagnosis of lung cancer is delayed, and so they are later stage. If we can catch those cases early stage, you can see the stage 1 5-year survival rates range from 73 to 90%. So that's a group that we are targeting with screening. Screening with low dose CT, which is what LDCT stands for, has been shown to decrease lung cancer mortality. Next slide. So the 2021 new recommendation statement replaces the 2013 recommendation statement. The new recommendation statement is based on a systematic review of approximately 223 publications, including 7 randomized controlled trials. The 2 largest are the NLST, which is the older study, which included 53,000 patients, and then the newer Nelson study includes 15,000 participants. They also did a decision analysis modeling using the CISNET network. This lung cancer screening is a B-level recommendation, which Dr. Jenkins showed the definitions of those in the prior talk. Next slide. So why, what spurred the update? 2 big things is the release of the Nelson trial data. This trial, as I said, was the second largest RCT and was released in 2018. And so the review of all that data to add to what we knew from the NLST. The Nelson study showed a 26% decrease in mortality with screening versus 20% from the NLST. So increased mortality and confirming the NLST data. Interesting in the Nelson trial, which is information that went into the recommendation statement, is that 1/4 of their patients were actually under the age of 55 years. So younger patients were in this study. And also they had a lower PAC year history as compared to previous data. The number needed to screen to prevent 1 lung cancer death came out as 130 in the Nelson trial compared to 323 in previous data, which has to do with the longer length of scan time and data collection. Also, there's new data coming out that addresses healthcare disparities based on race and how they pertain to screening eligibility, particularly in the Black and Latinx community, where there are higher rates of lung cancer with less PAC year history and at younger ages, which the recommendation statement also tries to address. Next slide. So what are the differences? Very briefly, so the 2013 recommendations, there's this little monogram that they use, but A is for annual, 55 to 80. So the 55-80 is for the age range. The PAC year history is 30. And then the patient has to be a current smoker or has quit within the past 15 years. So that was 2013. The only changes are that in the 2021 recommendations, the age range has been lowered from 55 to 50. And the PAC year has been lowered from 30 PAC year history to 20 PAC year history to be eligible. Annual screening and either a current smoker or someone who has quit within the last 15 years are unchanged. Additional considerations are that you discontinue screening once the person hasn't smoked for 15 years if they've been screened, or if they develop a condition not lung cancer that substantially limits their life expectancy, or in a patient who would either be unable to or unwilling to undergo surgery, because that really is the main option. And so those criteria need to be met. Next slide. So in implementation, this has been the difficulty with lung cancer screening and will continue to be. But for implementation, key features, there needs to be smoking cessation counseling going on. Prevention and smoking cessation is going to be our most important tool to prevent lung cancer, no matter what other screening we're doing. Shared decision-making, where the discussion of the benefits, limitations, and harms is had with the patient before they go to screening. Ideally, you would refer the patient to a center that has experience and expertise in lung cancer screening. And then this center would be using some kind of standardization. What we use in radiology is the LungRads program. So this is it's a very busy, colorful table, but it breaks down every nodule, anything we might find by size, whether it's new, old, has it grown, where it's at in the lungs, any other features, and then gives specific recommendations for what to do next. This helps in discussion, it helps standardize how we're following these patients, and it decreases the false positive rates as well as unnecessary interventions, which is very important. Next slide, please. Now the harms of screening and treatment, the new recommendation statement spent a lot of time on this because this is a big concern for good reason. So for false positive results leading to unnecessary tests and invasive procedures, the NLST reported a 26% rate of false positives on the baseline screen. That number goes down with subsequent screens, and under 2% for invasive procedures for those false positive rates. The LungRads criteria was not available at that time, but going back retrospectively and going through the data, just using LungRads was shown to decrease false positive rates at baseline screens to 12.8%, and also decrease the number of invasive procedures by 23%. So that's key to protect the patient from that harm. Radiation-induced cancer is a big issue in the media. Part of the problem is this is all estimated risks, and we don't have great data for how this is going to play out. So more to come. But low dose CT, just to give a general idea, the range for radiation dose is 0.65 to 2.36 millisieverts. And if just being alive in the United States during the year, just going about your normal business, you'll receive 2.4 millisieverts of background radiation. So that kind of gives some kind of framework for what those numbers mean, which helps, with discussions with patients. Again, we don't have good data. Everything is with, estimations and modeling. But at one of the modeling studies estimated that the lifetime risk, that there is a lifetime risk of 2.6 to 8.1 major cancers per 10,000 people screened after 10 annual screens. Next slide, please. Overdiagnosis is a big one. And unfortunately, there isn't a lot of great data. Hopefully this will, again, more to come. But the CISNET did do a modeling study that estimates 6% of the screen detected cancers are in that category of overdiagnosis if we use the 2021 screening program. Incidental findings, big range depending on what you classify as incidental, which has not been consistent in the past. And you can see there 4 to 40% have, quote, incidental findings. But some of these are very important. And for example, in NLST, 0.39% of patients in that LDCT group were diagnosed with kidney, thyroid, and liver cancers. And I'll just say last week, we had a lung screen that was negative for nodules, but the gentleman in the last year had developed several liver masses that look like metastatic disease. So now he's getting his workup for that. And then increased stress and anxiety has been reported, but that's really just in the short term while people are waiting for the results, which is a very, within a week or less for our program. Next slide. Okay, so super brief. We started our program in 2011. We've screened over 2,100 patients. I think the big key is that wherever this lung cancer screening is being performed is that you have a multidisciplinary team, which obviously is difficult in the implementation process. Here we have pulmonology, radiology, thoracic surgery, oncology, infectious disease, and family practice all involved in the screening program. And next slide. Last slide, just for what's happening in the real world and also how COVID has played into this last year, because our screens have absolutely declined during 2020. So this is a 60-year-old female. So she fits in that 50 to 80 year age range for eligibility. She has a 37 pack year history, so greater than 20 pack years. And then she had quit smoking 4 months prior to undergoing her baseline screen. So on the left-hand side of the screen, in August of 2020, you can see there's a small nodule there, about 10 millimeters. She was recommended, we use lung rads, she was recommended for a 10 millimeter nodule to have a 3-month follow-up chest CT. She did not return at 3 months because of COVID. That was our time for being right in our peak, and she was worried about coming in and having that done at that time because of COVID. So she ended up coming in as numbers started to decline. And so she ended up coming back at 6 months. And you can see that nodule is it has doubled in size, has some small bronchial dilatation associated with it. And so at this point, guidelines are to biopsy. So she went to our interventional pulmonologist and had a biopsy, and this is a non-small cell lung cancer. Luckily, she's had her EBUS, her mediastinum lymph nodes have been assessed, and they're negative. So she's on the schedule to have a partial lobectomy to remove this, and she'll be in the stage 1 category. So we'll have a good 5-year survival rate. And that's the end of my discussion. Thank you.
Great.